Is it raining down there?
It is. It's sort of like pop-up little showers.
I'm hoping it keeps raining here. I start my shift at 5, so.
John, you doing okay?
It's been a long week, Herb, but I'm here.
Every one of your weeks is long.
Hey, Dr. Winslow, nice to meet you unofficially.
Nice to meet you. Appreciate y'all having me.
Hello, Dr. Bortela.
Hey, you guys got me?
Yep, now you're good to go, y'all.
Okay. All right. Well, I've been talking for the last 5 minutes to myself, evidently, but I'd like to welcome everybody to this vaccine hesitancy and COVID discussion for Pitt County and whomever else decides to join in. It's my pleasure to welcome Dr. John Silverdale, the Pitt County Public Health Director, Dr. Herb Garrison, who's ECU EMS physician, former Highway Patrol Medical Director, and a VIP as far as I'm concerned. Thank you for joining us. Dr. Trip Winslow, who's the North Carolina State Medical Director and extreme friend to EMS, and has family here in the eastern part of the state that I just learned. So, and Dr. Roberto Bortela, who's the Pitt County EMS Medical Director, is sitting here properly social distance from me here in the EOC, joins us as well. And guys, I just want to introduce this informal panel discussion. Would like to discuss some vaccine hesitancy and first responders primarily. You know, there's a lot of discussion, politically charged and otherwise, running around regarding COVID and the vaccine availability. So I'd like to discuss that today. And then there's a few other questions that I have that I want to let you, the experts to EMS, discuss. And first and foremost, I'd like for each one of you to just kind of introduce yourselves individually and tell the folks that are watching a little bit about yourself quickly, and then we'll jump right in. Dr. Silverdale actually has a short PowerPoint regarding responders and vaccines that he'd like to share with us. So, Dr. Bortela, would you like to start?
So hi, I'm Roberto Bortela. Like Jim says, I'm very grateful to be here. I'm the medical director for the Pitt County EMS system. I'm also an emergency medicine physician from ECU with a subspecialty in EMS. And also I'm a retired lieutenant colonel from the Army. So that's kind of my background.
Dr. Winslow.
Oh, yes, sir. I grew up in Person County. My grandfather was actually born over in Perquimans County, grew up in Gates County. I went to medical school at UNC, did residency and an EMS fellowship there. Graduated fellowship in 2003. I've been at Wake Forest Baptist in Winston-Salem ever since. In fact, I'm gonna go work there later on this evening. Been medical director for North Carolina Office of EMS since 2011, I believe. And I really like, working with EMS in North Carolina and a great bunch of people. And I appreciate the sacrifices they make every day, especially during the global pandemic.
Fantastic. Thank you, sir. Dr. Garrison?
Thanks, Jim. My name's Herb Garrison. I'm a professor of emergency medicine at East Carolina University, where I've been for now going on 27 years. I've served in a number of roles, starting from in EMS, including, I think like Dr. Winslow, was a member of South Orange Rescue Squad, worked as a paramedic there, and then was the first EMS fellow to graduate from the ECU Emergency Medicine residency, served for a number of years on the North Carolina EMS Advisory Council, and worked also, as Jim said, as one of the medical directors for the North Carolina State Highway Patrol, and then also worked for the North Carolina Department of Health and the Pitt County Health Department as one of their bioterrorism physicians, and right now have the honor of serving on Dr. Silverdale's Board of Health. So lots of roles, and still love EMS as my first love.
Fantastic. Thank you, sir. And Dr. Silverdale, I'll let you introduce yourself, and then if you want to dive right into the discussion that you had.
Okay, thanks, Jim. Thanks for the chance to be here this afternoon and participate on a panel with such esteemed colleagues. I am a crazy recovering Yankee who grew up about 30 miles south of Albany, joined my local volunteer fire department in 1983, so 38 years ago. Past captain, past chief medical officer for my local fire department and fire district. Was also a state fire instructor and chief medical officer for our state urban search and rescue program from 1999 to 2012 when I moved down here to join the faculty at Brody. My responses with the USAR program include the World Trade Center on 9/11, the Binghamton floods in 2006, several other moderate to high complexity incidents across New York State with them. As a physician, I originally trained in family medicine, did a second residency in general preventive medicine and public health, and I've practiced in occupational medicine for more than 20 years as well, predominantly serving first responders as my occupational group of greatest interest. So I wanted to start this afternoon off with just a few slides to talk about general responder health and safety issues, and then we can dive into the COVID issues. And I don't want to miss a chance to talk to responders and not address some of those general public or occupational health issues with them. So let me go ahead and I'm going to share my screen and we'll get you started here. And click on that. There we go. And I'm going to minimize that window so I can see. Good. All right, guys. So there's me. And like I said, I've worked on general responder health and safety for years, running my own practice in upstate New York that served 29 fire districts in 4 counties, several EMS agencies, several law enforcement agencies. And I think it's worth at the start of this discussion to take a few minutes and think about health and safety for responders in general. So it's a complex and lengthy subject. To me, I see the key areas of responder health and safety as initial and periodic health assessment. That includes things like respirator medical clearances and fit testing, review and updating of vaccinations. And there are a lot of vaccinations that most of us have had. Sorry about that. I've got some folks here doing some work. Reviewing and updating vaccinations, a lot of common vaccinations that we get across the workforce, especially in emergency services. And then age and occupationally appropriate medical screenings. Make sure you can still hear, make sure you can still see, things like that. Screening for occupationally related cancers, other things along that way. Exposure tracking and post-exposure evaluation. Infection prevention and control, one of my pet peeves in responder health and safety. Hazard recognition, and boy, do I have stories there, but we don't have enough time to go through all of those that I've seen over the years. And then a little bit of training. I think training is really very important. We can weave health and safety into our trainings every time we go out to the training board or to the drill ground or wherever we're going for training. My postulates about first responders. Responders often get into the soup before they know what the soup is made of, meaning we run towards the things everybody else is running away from without regard to what that incident is. Somebody needs help and we go. It's a noble part of being a first responder. Responders do a good job of don't do a good job of protecting themselves from the things they can see, let alone things they can't see, like toxins and microorganisms. And responders must be trained to recognize the hazards in order to protect themselves from those hazards. Talk for a minute just about initial and periodic health assessments. This, you get it at appointment or when you go on the job, really should be annually thereafter. That's a detailed history, detailed examination with some point of service laboratories. Won't bore you with all the details, but I think very important. And over the years, I've made a lot of significant diagnoses doing firefighter examinations and other responder examinations right in the clinic. Review and update of vaccines. You know, most of us have had the hepatitis B vaccine. And if we look back at the early 1980s, when this was first required by OSHA, it was very controversial at the time, but now almost all of us have had it. Tetanus, which usually includes diphtheria, may include pertussis vaccine as well, boosted on schedule. And most of us, or many of us, get an influenza vaccine every year. And for some responders, it's worth considering hepatitis A vaccine. There have been large hepatitis A outbreaks in major metropolitan areas, including Charlotte, North Carolina, and other parts of the state. And responders, again, may be exposed to this highly infectious disease, and it may be worth protecting our responders. And then again, respirator medical clearance and fit testing, which one of my gripes is often refers to just completing the OSHA questionnaire, which is inadequate in my book, but that's another argument. Post-exposure tracking and post-exposure evaluation. We get exposed to lots of things in the job, on the job, chemical hazards, for example, pesticides, radiologic hazards, infectious diseases. That's driven really by the bloodborne pathogen standard from OSHA. But if you look at the NFPA and line of duty injury report every year, you'll see there's probably the better part of 20,000 infectious disease exposures across just the fire service every year, not including non-EMS or non-fire providing EMS agencies. So a very big problem in emergency services. We don't often think about dust and fibers, but they're still an issue, still asbestos around, still lots of other fibers and dust that can be hazardous to our respiratory tree. And again, one of the neglected things is often occupational noise or occupational vibration from an exposure standpoint. Infection prevention and control, definitely an area where we can improve. Years ago, there was a National Fire Academy course on infection prevention or infection control in emergency services. That's, I think, long been out of the catalog. I know I haven't taught that in years, and I don't think that they have put that back in the catalog. This is often overlooked or inadequately covered in first responder trainings. When I teach about this or train folks about this, I usually do it in 6 topic areas or 6 units. Airborne and droplet infections, things like influenza, meningitis that are spread by respiratory droplets. You might throw measles in there, that's airborne spread. Bloodborne pathogens, this is the required ticket that gets you in the door. It's OSHA required to be done when you come on the job and then annually thereafter. I spent some time talking about food and waterborne pathogens. We've done a lot with responder rehab. And when we serve food and water in austere environments, let's call them, we can see contamination issues with food and water. So very important to make sure that we handle food and water properly in the field. Usually cover environmental pathogens, rabies, scabies, Lyme disease, things like that. Down here, Rocky Mountain spotted fever that might be acquired from operations in the wild. Do a unit on bioweapons and bioterrorism, and then talk about emerging infections, which are things like COVID, new infections or infections that have become of public health concern recently. So I think it's important that we include that training into our training of responders. Hazard recognition, again, we get in the soup before we know what the soup is made of. Things we often miss, electrical hazards. Had a state trooper in New York want to open a energized vehicle one afternoon with live primaries on it. Had to say, no, trooper, you're not doing that. Carbon monoxide, even seasoned responders sometimes fail to recognize the potential for carbon monoxide. was on a training deployment when our communications unit, the carbon monoxide detector went off in the unit, and the communications officer decided to disable that carbon monoxide unit instead of asking for help. He had a mild carbon monoxide intoxication on that deployment. Structural weakness and structural failure, we need to do more training in that area, and certainly many, many more topics in terms of hazard recognition. Last, training, we've got to train for the common and uncommon responses. Things we don't do often, we don't do well unless we practice them. Thanks, Gordon Graham. I'm sure a lot of you are more familiar with Gordon Graham. Predictable is preventable. Thanks, Gordy. Remember, it's the low frequency, high consequence events that get us into trouble. And with that, I'll get off my soapbox and let somebody else talk.
I guess based upon that short presentation, do you guys have anything to add you want to add on that?
Or tell me I'm crazy.
No, one thing that I would point out is, like you said, is one of the things that you do in occupational health is review vaccinations. And we know that there's vaccination requirements for health professionals. It's a long-standing tradition. This is nothing new. Like you said, having hepatitis B, we know it's or updating your tetanus is something common, and it's done, and it's to protect the healthcare professional. It's that simple.
Yeah, absolutely, Bobby. Over the years, we've given hundreds of tetanus vaccines at fire department physicals, hundreds of hepatitis B vaccines. We did some hepatitis A vaccination for a couple of dive teams that we worked with. Very common to give vaccines in occupational health settings, especially where it involves first responders.
And you can say, and like you said before, like the example for Hep A, the circumstances dictate additional requirements. Me, from my military background, obviously, depending on where I went, added a couple more. When I deployed abroad, then it went from the traditional just healthcare vaccines to yellow fever, anthrax, smallpox, stuff like that, right? Because there was an additional risk, and the idea was to protect us.
So let me ask Dr. Winslow, Dr. Garrison, you may be able to add some more. So how does the occupational health side of that, as it relates to vaccination, in our initial training and education, how does that transition and relate to the COVID vaccine that's available, the early R&D into that, and first responders being willing to be vaccinated in the current climate?
You want to go ahead first, Trip?
Sure. I mean, I think there's a very long history, as I already mentioned, of vaccines being required for workplace, especially for healthcare providers. At this point, these are they're approved vaccines which have been through the full testing. We're not in Russia or China where they skipped phases of testing. All these vaccines for COVID have been through full phase 1, phase 2, and phase 3 of testing. And the most important was the phase 3 of testing, where they had to have at least 30,000 people, and they followed those patients now for well over 3 months. And that phase 3 testing, where they had over 30,000 participants, is really important, because that's where you find out the 1 in 1,000 adverse reactions. And any adverse reactions you're going to have from a vaccine, by 3 months out. So these are probably the most studied vaccines we've ever had. We've used proven technology, the RNA, messenger RNA technology, as well as some of the DNA technology, to come up with these vaccines. And they're very safe and proven vaccines. They don't stay in your body. They don't change your DNA. They're extremely safe, and they keep us safe. And honestly, even more importantly, they keep our patients safe. And I think it's really important that we take these vaccines.
So I'm going to take a different tact. I agree with everything everybody has said, that I think it's part of your duty as a clinician and a medic to do things that keep your patients safe. and keep you safe. When Dr. Silverdale's predecessor, Dr. Morrow, hired me to be one of the state bioterrorism doctors, the first thing he said I had to do was get a smallpox shot, just like Dr. Bortela did. And without a moment's hesitation, I got one. I was old enough to have already had one before, but it was just something you did because it's part of the job, because by the time you are exposed to smallpox, it's too late to say, well, I'm going to go out to get something that's going to prevent it. But my reason for getting the vaccine is totally self-serving. And let me tell you why. So when I'm in a car, I wear a seat belt and I drive defensively. And I do that because I don't have time to mess with the consequences of a wreck. I have a finite amount of time in my life to get stuff done. And I got a lot of stuff I want to get done. And if I have a car wreck, then I'm going to have to deal with the responding officer. I'm going to have to deal with the insurance. If I get injured, I'm going to have to go to the hospital. And I just don't have the time to mess with all that. And so I do what I can to prevent myself from getting in a car wreck. And I think of the vaccine for COVID as the same thing. I don't have time for long COVID. I don't have time to be in the hospital. And I know that this thing is safe and effective, so I'm going to take it because I don't want to deal with the potential consequences of it. The other thing I'm into big time is risk reduction. And I sort of think, I don't know if anybody out there is Star Wars fans, but you know how Captain Kirk would say to whoever was driving the machine, get the shields up, we've got some stuff coming in. Well, what the virus does for me is it puts up more shields against this COVID vaccine. And I want as many of the shields to go up as I can. I can't wait to get the booster because I think it's going to provide me with more shields. Again, because I don't have time to mess with the consequences of getting infected, having long COVID, having some sort of foggy brain. And so my approach to staying out of a car wreck and not getting COVID is all self-serving, and it makes the getting a vaccine sort of an easy call.
If he says Star Wars, you realize that
Star Trek. Yeah,
you realize that you offended a bunch of people right now, right?
Oh, Star Trek! I am so sorry.
So that's really good, guys. So I have two follow-ups to that. Number one, I'm hoping can somebody elaborate on, or maybe a couple of different ways, but can you elaborate on safe and effective? Because there seems to be this, I had several questions such as the vaccine magnetized, is there a tracker in it? Are there lots of different things? And so could you elaborate on safe and effective? And then can somebody, or maybe all of you can offer up, why are people surprised that businesses, especially healthcare facilities and EMS, public safety, why are we surprised about these increasing vaccine mandates? Because flu shots and others have been mandatory for years, right? So maybe that's the two-part question there.
Well, just as far as safe and effective goes, I mean, no matter what vaccine, no matter what medicine you take, there's always going to be some small risk of adverse reactions. But you definitely don't want COVID without being vaccinated. I know a lot of people, they come with this weird rumor that the vaccine can reduce fertility. Well, it doesn't. There's no evidence for that. No vaccine in the history of vaccines has ever affected fertility. But one thing the vaccine can do, and one of my residents who just finished a MICU rotation will tell you this, when he left that MICU rotation a few weeks ago, there was 5 women who just had C-sections who had to get their C-sections. They had bad COVID. They had to be intubated. They were still intubated and critically ill and hadn't seen their children. And we know that half the people who get intubated with COVID are going to die. So half those women are not going to see their kids. We know that if a pregnant woman gets COVID and haven't been vaccinated, they're 22 times more likely to die. They're almost 3 times more likely to have preeclampsia. Their kids are about, I think, 2.8 times more likely to have severe adverse or severe complications from that infection. And we're not talking mild. we're talking like interventricular hemorrhages and brain bleeds, anoxic encephalopathy, so brain damage, really bad lung disease, lung complications from the COVID. So the effects, I mean, if you're not vaccinated, I mean, regardless, you're going to get COVID sooner or later. And either you're vaccinated and you get a very mild illness, or you're not vaccinated and you have about maybe 2% chance of dying. And so you can have that protection, you can have that shield, or you can run the risk of getting really sick. And there's even some data showing that the COVID infection can even have some effects on male fertility, actually, because of the way it attacks small vessels and does other things. That they're still working on that data, but there is some data to suggest the actual COVID infection can have negative effects on male fertility. There is no adverse effects from the vaccine on fertility, though. And I think that's one thing people really need to understand.
And there were actually women that were enrolled in the initial trials for the Pfizer vaccine that became pregnant after getting they were in the trial, and they got pregnant afterwards, just proving the fact that even in the trial phase, it didn't do anything.
And a vaccinated woman, when they're breastfeeding their newborn, they have antibodies passed in the breast milk to the newborn to protect the newborn. And that's I think the best thing ever. People talk about, being worried about myocarditis. There's a very small chance that the vaccine might cause myocarditis in a very small group of people. There was a German study that just came out where they looked at 100 patients 71 days after their COVID infection. 60% of those patients had myocarditis on MRI 71 days later, and 80% of them still had some manifestations of that infection on the MRI. And that's the COVID infection. That's a huge number. So you can get the vaccine and run a very, very small chance of myocarditis, or get COVID without the vaccine and maybe run over a 50% chance of getting myocarditis in some studies. So that,
And if I remember correctly, the Israel study proved that again, that there's a mild chance of getting myocarditis with the vaccine versus a higher incidence of myocarditis with getting the COVID infection. So you are at more risk just by COVID to myocarditis than just the vaccine.
So people ask me, what makes you think this vaccine is safe and effective? And my answer is, I have the privilege of knowing a lot of doctors, and I consider physicians to be fairly smart and pay attention and able to read the literature and pay attention to it. And I watch what they did. And so actions speak better than words. And back in January, when the vaccine became available, even back in December, the group that I observed to get the most vaccine the fastest were physicians. And so quickly, about 90% of every physician all of the physicians that I know, and I know thousands of them, and I didn't take a poll, but 90% of all the doctors I know, if not 95% or greater, went and got the vaccine. And I don't think they would have done that if they didn't conclude that the virus was safe and effective. And that to me right there makes it an easy call, I think.
Yeah, I would add to that, Herb, from our experience at the health department. We've given now probably in excess of 13,000 doses of Moderna vaccine without a significant side effect profile. I've seen a few folks with so-called COVID arm, the red soreness at the red and swollen soreness at the injection site. I've seen that with other vaccines like tetanus and influenza. We did have one or two folks with some anaphylaxis. Some of that may have been more psychogenic anaphylaxis than true anaphylaxis. But we've seen no serious adverse events with this for an agency that's now given over 13,000 doses of Moderna vaccine. So very, very pleased with what we've seen in the folks that we've immunized with this. And so that's our personal experience at the health department with it. We've also given in excess of 500 doses of the J&J. We've done less of that, but we've seen none of the severe adverse reactions with J&J. but that's a smaller sample size in terms of vaccination.
And we haven't seen it. We haven't seen adverse reactions in the ED in the emergency department either. I mean, my colleagues here can attest to that. And if like some of the stuff that you hear or see in the social media that we're getting overrun by adverse reactions to the vaccine, then we should be seeing it, right? We are working in the emergency department and we just not seeing that. It's not a thing. In fact, the only patient that I have been taking care of that had a possible reaction to vaccine was immediately after administration, and it was maybe anaphylactic allergic reaction.
So, I tend to agree. You know, the science speaks for itself, and as healthcare clinicians, you know, paramedics and EMTs, we want for so long to be considered medical professionals and not other traditional names that you know are not derogatory, but you know, we don't want to be ambulance drivers anymore. We're clinicians and we're professionals, and we are. But it seems like, just like with the nursing community and others, we're having a hard time accepting the vaccine, and so there's a lot of surprise. And there's actually a comment in the chat, and I'll just share with you. Thalidomide was deemed safe and effective, and yet 10,000 children in several countries were born with deformities as a consequence of its use. So is there a way to, is just different, and the evolution of this vaccine is completely different, or is there a way, a short message to share with folks that I guess have a complete mistrust of us as government or as researchers based on what's out there?
I know they're probably more closely monitoring the adverse effects of this vaccine than anything else. I mean, they have something called the VAERS. I believe it's the Vaccine Adverse Event Reporting System. So that's being continuously updated. And then, you know, you got the Israelis. They were the first ones to jump on the boosters. And if there's anybody who's going to take care of their folks, it's the Israelis. I mean, they've got a very well organized healthcare system. They've got great data. They don't mess around. I mean, they just published a really good article. I can't remember if it's the New England Journal of Medicine or JAMA, looking at all these different side effects. And they feel extremely comfortable with this. They are already doing boosters of these vaccines. So it's not just the United States pushing this. It's the Israelis, it's other countries. And on top of that, we're using stuff like the Vaccine Adverse Event Reporting System to really keep a close eye on this. And I mean, I've seen no evidence that there's any adverse reaction to this. And on top of that, I feel bad for my administrative support person, because she's having to help me mail all the condolence letters I'm writing to paramedics' families who died and their agencies. I mean, just the other day, I wrote a condolence letter. I didn't get to write it to the family because the two orphans now. You know, an EMT just died in another part of the state, and now the two kids are left with the aunt. And you know, she wasn't vaccinated, and that could have been avoided, and that's not good.
But Jim, thalidomide was a drug that was used in the very late 50s, early 60s for morning sickness, and had some sort of sedative qualities to it. And it was introduced and put out for the public to start using with no clinical trials. Basically, they manufactured it and they just put it out there. And I think what's happened in the past 60 years is we've developed a system to whereby you can test things to determine that they're safe and effective. And that's exactly what's happened to these vaccines. I mean, the vaccine was developed for use months before it was used. And the whole idea behind warp speed was, can we first get it to the point of something that we can use, and then can we get it tested for being safe and effective? And it was put into clinical trials where they went around and with people's permission, they gave it to them, and then they monitored them for side effects to see what was it safe, meaning did it cause more adverse reactions in the people that got it than in the people that didn't. And these were randomized clinical trials. And then did it work? And so what they found through these clinical trials is that it was safe and effective. And that's entirely different from thalidomide, where they just put it out there. And we don't do drugs like that anymore. We actually put them through this very systematic and comprehensive testing thing. And people say, well, it went really fast this time. No, the numbers were huge. It went fast because there was a lot of people that would volunteer for the clinical trials because they wanted to see if it works. So that it's really an apples and oranges comparison to do something that had not been through any clinical trials.
And one thing that we have to be clear is there's nothing certain in life. There's not 100% in life.
Good point.
What we know right now is based on the data that we have, the real scientific evidence that we have is a safe and effective means of protecting yourself from COVID. In 20 years, can we find something that happened? Maybe. No medication is approved 20 years later. That doesn't exist. It goes through the same trials, the same clinical trials that the vaccines went through. So I cannot tell you what's going to happen in 30 years. Nobody can tell you that. And nobody can tell you. And even if we tested it for 20 years, we can't tell you what happens at 35 years. So there's not 100% in life. What we know right now is safe and effective. And comparing it to something that happened in the past, it's not, like you said, it's kind of sometimes it's not fair because we don't have the same safeguards. We don't have the same type of clinical trials that we're going through. We don't have the same exchange of information that we have at this point. Talking about how fast this vaccine was developed, there were multiple countries collaborating at the same time, sharing clinical data, information of manufacturing. People volunteered to be in clinical trials in masses. Well, that hadn't happened before. So it was a global effort that unfortunately doesn't happen for a lot of times for a lot of things.
So
Go ahead, Jim.
you're good.
I was going to just pick on something, or not pick on, but pick up on something that Dr. Winslow said. The veyer system's been a longstanding vaccine adverse events monitoring system. Anybody can submit a VAERS report. It can come from a physician. It can come from an individual. Someone can do it on your behalf. So that information goes in. We've also, with this, had the VSafe program, which is an app-based program that vaccinated individuals have been encouraged to participate in, that does surveys for adverse events at certain time frames after the vaccine has been given. So if you've signed up for VSafe, it'll remind you to do the brief survey about adverse events, where VAERS is more passive in that you have to initiate a VAERS report.
So I had another viewer question, that sort of Dr. Winslow's relates to what you were saying. It was asking, is our message incomplete to EMS responders and I guess to the larger public? But he was saying he didn't realize there were risks of myocarditis or other reactions from the vaccine or from COVID itself, and that when you give a large volume of the vaccines, is the number of reactions actually low compared to other vaccines, or is it normal? Is there a better way for us to get the messaging out?
Well, I mean, Dr. Silverdale and Dr. Garrison probably speak more to this, but I always think we can do more education, because I firmly believe that all the EMS personnel and providers are professionals, and they need to know as much as they possibly can. Obviously, you want to pick your sources and have reliable sources that can give you solid evidence. But I personally try to visit as many EMS agencies as I can and talk about why the vaccines are important, what's involved with COVID, why it's so important to have immunity to COVID, because it's not like the flu. It's a very dangerous virus that's really sometimes very random on who it makes critically ill and kills. I think we need to do as much education as possible, which is why I really, like the fact that you're all having this roundtable here. And I think this is extremely important because our providers have had a horrible last 18 months. It sucked, quite frankly. It's been challenging. Our providers have been through things I think they never would have imagined they'd been through. And I respect the heck out of them for what they've done. And I want to make sure we educate them as much as possible because I think they deserve our respect. And I think they want accurate information. So that's, I really appreciate what y'all are doing today.
I will say this, and maybe we should have we should have made that clear at the beginning. None of us have any economic disclosures about vaccines, right? No, I don't have stock in Pfizer. I don't have stock in Moderna. Nobody pays me to give vaccines. I don't get more money if I see more COVID or more vaccine-related injuries. I volunteer with Dr. Silverdale to provide vaccines to the population of Pitt County and our first responders willingly. And why did I do that? Because I give a crap of people not dying. I wouldn't recommend the vaccine to my family and my friends and myself and my kid if I didn't think it was safe and effective. I didn't think it would do something. That my whole reason to be here today is because I care about the people on the other side of the screen that they're going to be safe. It's plain and simple.
And I greatly respect Dr. Bortela's leadership. He sees this every day in Pitt County. He works with the EMS providers there, and he takes care of patients in the emergency department. And I just appreciate all the leadership y'all are having locally because what y'all are doing. These events are extremely important. And Dr. Bortela sees it every day with his own eyes. He sees what the paramedics see. He sees what happens in the emergency department. And we have to protect ourselves and our patients and our families.
Yeah.
Jim, I'm sorry, John.
Oh, go ahead, Herb. You can go first.
I just wanted to echo that to answer to your question, have we educated enough? I think the answer is no. And do we need to educate more? The answer is yes. I believe in the teaching model of repetition leads to comprehension. And so that's why I'm so glad that we're doing this. And I think any of us would be willing to, if agencies and organizations and squads wanted to have us come out and talk about it in person, I know I'd be willing, and I know anybody on the screen would be willing to go and have more in-person conversations if that would help.
Yeah, absolutely. One of the things we've been trying to get off the ground is get out and have more interaction with our first responders through the health department from a health and safety standpoint. I would also, Dr. Winslow made the point that this is unpredictable in terms of its clinical behavior, and that even though somebody might on paper be low risk, it doesn't mean that they don't have a severe case of COVID or even die. We've seen low risk individuals die. Certainly there are things that make some people more susceptible to severe disease or death, but the behavior of this virus is unpredictable. And we encourage you to take steps to protect yourself. Again, I wouldn't be here as a longtime firefighter and responder myself advocating for vaccine if I didn't think it was safe. I wouldn't have taken it myself or had my wife take it if I didn't think it was safe. So I encourage you to think about that while you can make an argument of, I don't know what it's going to do long term. Well, nobody knows what any medicine is going to do long term when it first comes out. It's not FDA approved. FDA approval doesn't guarantee safety. There have been lots of FDA approved drugs that have been withdrawn from the market afterwards. So emergency use authorization is not a bad thing. If you've been tested, chances are the testing system that you used was run under an emergency use authorization. For folks getting Regeneron or other monoclonal antibody therapies, those are being given under emergency use authorization. So EUA has been kind of bad-mouthed in regards to the vaccine, but it's a process that allows a drug to get to people in times of emergency quicker than going through the full FDA regulatory process, which now Pfizer has done, and the other vaccines will too at some point. So a couple of things to think about.
So Dr. Silverdale, I think we've had increased, numbers of people getting vaccinated. And it sort of feels like everybody who really wanted to be vaccinated has gotten it, in the first 6 months, before the summer. So, now the government has taken a different posture towards the vaccine and is, the different mandates. And I mentioned it earlier, but, in healthcare, we seem to be surprised that facilities and businesses are requiring us to be vaccinated or tested. And I don't know why we're surprised, because I'm given understanding the flu vaccine was mandated in a very similar way to this 25 years ago in the same facilities, and it still is today, and it's sort of second nature. And flu is similar to COVID. It changes every single year, and the vaccine is never perfect, but it does the same thing, right? It lessens the chances of a severe reaction. So, how do we address the concerns about breakthrough infections, and that segment of our first responder community and healthcare workers that are my body, my choice, or they're just absolutely terrified? What is the basic information that we can share that is helpful there?
Well, I think the breakthrough rate right now, Jim, is probably somewhere between 18 and 25%. There was some data that reported out by the state epidemiologist a few weeks ago, where we were seeing about an 18% breakthrough, meaning folks who were vaccinated getting the disease. I saw some data out of Vidant locally, where about 25% of folks in the hospital at Vidant were breakthrough cases. You have to understand the concentration that goes on in terms of patients getting to a large medical center like Vidant. So that 25% is probably a little bit on the high side, but that's their tertiary care experience. Sorry, what was the other part of your question, Jim?
I just, how do we address, that we're sort of beating the bushes trying to get information out there. This whole meeting today is, sharing the facts on how do we dispel the social media and the rumors to convince folks that even though they're vaccinated, they can still get sick, right? We've gone through this safe and effective, but can you also point out the chances of death or very serious? Are there numbers about that? If you've been vaccinated, your chances of dying from the illness or very serious ICU stay are much less.
Far greater. We look at, my colleague Jim Madsen over in Beaufort County looked at his county data, and you were about eight times more likely to have severe COVID, end up in the hospital, and or die if you were unvaccinated as opposed to being vaccinated. And even if you say, well, I can take the vaccine, but I can still get COVID. Well, yeah, but if you've been vaccinated, you're probably not going to get terribly sick, and you're probably not going to die with a breakthrough case. Where unvaccinated, again, the behavior of this virus is unpredictable, and even folks who we may think are low risk sometimes get very sick with COVID, and even sometimes die from COVID.
I think the seatbelt analogy, it goes again, right? If you wear your seatbelt, you have airbags in your car, drive defensively, you have less chance of being in a bad motor vehicle accident and dying. Versus you don't wear your seatbelt, you're in a car that doesn't have airbags, and you're going 100 miles an hour. It's just, you're minimizing risk if you're vaccinated.
Yeah. There was also a good study that came out in the MMWR, which is Morbidity Mortality Weekly Review. And I think it came from some data from July 4th up in Massachusetts, where they had this huge resort town. They had 60,000 people come in for basically one huge party. 70% were vaccinated, and it was basically a stress test for the vaccine, because they're in bars, they're in enclosed spaces, they were literally dancing together, singing in each other's faces. So if they're going to get large amounts of exposure, that's the place. And they had 346 vaccinated people get COVID. Only 4 were hospitalized. and 2 of those had significant comorbidities, and none died. And that's a heck of a stress test right there. So I think that's an important thing to remember. And I believe at least one of the large hospital systems showed that 93% of the patients in ICUs were not vaccinated. So I think that's a very important thing to remember, because you can still get sick, but I think a lot of some data out of Connecticut and Minnesota, I believe, showed almost all their hospitalized patients were like 75 or 82 in kind of that older age group too, who were vaccinated.
And by then it goes the same more or less way. Right now, in August, I had the last numbers in August when they gave it to us. I mean, at that point, there was only 1 vaccinated patient out of the 33 that were in ICU. And all the patients that were in ventilators, out of 21 patients in ventilators, only 1 was vaccinated.
So the data more or less speaks for itself, right? The science is solid. The statistics are glaring, and so it's very difficult. And I know in all the different communities, EMS and our first responder community, I think we've aligned sort of with the nursing and other healthcare professions that we're still having a hard time dispelling the fear when our employers tell us we have to get vaccinated or be tested every week. And is there a message that we can share? I know we cannot defeat the social media. We can't beat Twitter and Facebook and all the experts in internet land. But what can we do that maybe we're not doing, or do you have ideas here that we could do to reach the folks on the fence?
Well, I firmly believe that every paramedic out there and pre-hospital provider is a leader in their own community. They're looked up to because paramedics and EMTs, they take care of people when they're probably the most critically ill or more scared they've ever been in their lives. I mean, they go and touch people literally when they think they're going to die. And so I think we forget this sometimes, but every single one of those providers is a leader in their community. People listen to what they say and they want to hear what they have to say. So I strongly believe that all providers should seek out as much information as they can, educate themselves, and also become leaders in their community to help protect their community by helping to educate their friends and neighbors about why vaccination is important. Because by doing that, they're going to protect themselves, they're going to protect their families, and they're going to make their community a better place. And a healthy community cannot function when the hospitals are completely full with unvaccinated folks who are critically ill and can't take care of the rest of the community. And paramedics and EMTs are held in high esteem, and people listen to their opinion and their thoughts. So please don't undersell how much of a leader every single one of you is in your communities, because what you do is extremely important. You do things that other people can't imagine, and they listen to you.
Can I play off of that, Jim?
Yeah.
Because I think Dr. Winslow is exactly right, and I would just take it from a different angle. So you mentioned earlier that people that work in EMS are professionals, and I truly believe that they are clinicians of the highest order and critical in our healthcare system. And I think what distinguishes a professional are 2 things. One is you have relative autonomy, and I think our clinicians do. When EMTs and paramedics are out in the field, that they have a lot of flexibility in what they do for a given patient. They are there by themselves, evaluating, initiating treatment, etc. So that's one side of the being a professional, is you have relative autonomy. The other side is that you self-manage, meaning you keep up with the literature, you educate yourself, and you do the right thing. And so in order for for us in EMS, physicians, paramedics, emergency medical technicians, in order for us to distinguish ourselves as professionals, we need to exert our autonomy, and we need to self-manage. And part of that self-management is doing the right thing to keep yourself safe and your patients safe. And then again, that makes the vaccine an easier thing to say. As a professional, I do this because all my peers, my nursing peers, my physician peers, the other people that are professionals in healthcare, they are doing the same thing.
Something I wanted to mention before our time runs out. So, and one of the, the topic was vaccine hesitancy. I do want to highlight that it's not the whole population. If you check the dashboard, the North Carolina dashboard right now it's 87% of the population over 65 is fully vaccinated. They were not hesitant. And I think part of it is, one, they have gone through other stuff before. They have gone through pandemics before. So it gives them a different perspective. But it's where we are falling, we're missing the mark. It's in the younger population right now. The older population over 65 is really embracing this, and they have a lot of experience. They have gone through other stuff that I haven't gone through. And they tend to agree, for what I see right now, they tend to agree with us.
Yeah. Bobby, to build on that, there's an interesting parallel in history that many of the folks who were first to receive the polio vaccine back in the 50s are now the first that received the COVID vaccine. In fact, our PIO department put a little thing together about that called the Vaccinated. It's out there on YouTube. So that our elders, had no problem at all taking this vaccine. Many of them wanted it. They were beating our door down for it. Early on, well, you guys remember, because you were there with us when we first got the COVID vaccine. The first responders were beating our door down for it. We sent you and Jim out, and thank you. Let me say thank you publicly to you guys for going out to the different firehouses and EMS buildings across the county to give shots on behalf of Pitt County Health Department. Thank you for that. We appreciate it. And so it, I kind of struggle a little bit with folks who are reluctant to take the vaccine. I understand it to some extent. It's new. There's a lot of mixed messaging out there about the vaccine. But like I said, we've given over 13,000 doses of the Moderna at the health department with nothing more than what we would expect from any other vaccine in terms of side effects. Local soreness at the injection site, local reactions, and maybe feeling mildly ill for a couple of days after the vaccination, usually a little bit worse in somebody who's had prior COVID disease themselves. But really what we would consider pretty typical post-vaccination side effects. So I would encourage that. I'd also say, if as a responder, you're willing to crawl through, toxic materials, crawl through smoke or fire, brave other infectious disease out there in the performance of your duty, but you're reluctant to take a vaccine in which, in Pitt County, we've given, like I said, over 13,000 doses of Moderna, and across the country where there's, I think now over 160 million doses of these vaccines having been given. If you're reluctant to take that vaccine, but you're willing to brave all these other hazards, you might want to look at your assessment of that hazard matrix and say, is the vaccine really that bad? And really think about it. Is this vaccine really that risky, and compared to all the other risks that I bear as a first responder? And I would encourage folks to do that sort of self-check.
Amen, Dr. Silverdale. So I know we're sort of running out of time. We planned for about an hour today. It's 4 o'clock. I know you want to be mindful of y'all's time. And so I think what I've come up with is that if you all were willing, then I would like to try to do this again, maybe a part 2, and then we maybe look at some other things in a couple of weeks, not waiting months to do this, but maybe shoot for a couple more weeks and maybe another hour. And if you have other things that you're seeing, I know Dr. Winslow, you discussed this all over the state, and So maybe we try to reach a wider audience with our discussion here. But, you know, one of the questions somebody wanted me to ask, and it's sort of open-ended, and I don't expect an answer, but, you know, when will the pandemic be over? And then, you know, based on a tremendous amount of data, is this a bunch of junk? You know, is it something we have to be afraid of? And so maybe take that, and I don't know if somebody wants to give a short answer as we start to close, but is it something that those are the things we bring back for our next discussion?
My shorter answer is this will be over or close to be over when we get enough people vaccinated. That's the way out of this pandemic and get back to normal society, normal schools, normal life for our kids, is that we get everyone vaccinated. That's my short answer.
And that's the correct way, because the other way is we get more people that are unvaccinated and die. And I don't want that way. I want the way where people get vaccinated and we save them.
Dr. Garrison or Dr. Silverdale, is there anything you want to add as we close? You know, like I said, I want to be mindful of everybody's time, and you guys are extremely busy. I'm very proud. You know, I just want to say as we get ready, though, I'm extremely proud that you're willing to come on today, everybody, and as pillars and respected physicians in our community, it's an incredible opportunity. So thanks, and I'll let you guys have a couple of closing remarks if you like.
Thank you for inviting me. I'm always available to come in any EMS agency who speaks, but thank you very much.
Yeah, this is this has been an honor. Last week, John said that we had some esteemed physicians to be on this panel, and I said that's the first time anybody's ever called me esteemed. So these are some of the best physicians that I know in the state of North Carolina, and it's such an honor for me to be part of this panel and talk to a group of people that I love dearly and who take care of the state that I love and take care of the county where I live. And so it's just an honor and a privilege, and I appreciate everybody out there and appreciate y'all for calling this together.
Yeah, definitely. I do think of Herb as an esteemed colleague, and I'm happy to now consider Dr. Winslow an esteemed colleague as well. And of course, Dr. Bortela, Bobby has stood shoulder to shoulder with Pitt County Health Department and with me throughout this campaign, and I really do appreciate that. And Jim as well. Whenever we've needed something from EMS, Jim or his boss Randy have literally bent over backwards to help Pitt County Health Department through this. I do appreciate people's frustration. I think, you know, when I look at the epi curve and I see the low point we hit in about mid-June, it was the week of June 19th, and then we started climbing, and that this was Delta, and Delta really rewrote where we were in the pandemic, and it clearly is more infectious than the original variant, where the original variant, for every case we counted, we had at least 2.5. You know, we knew, most of us were guessing it was between 2 and 3, and then serial surveillance came out and really supported that it was, you know, when we had 10% of the population known to have had COVID, about 25% of people had antibodies. And we're thinking with Delta that it's probably more like 6 or 7. So in some ways that's good and bad. It's good because a lot of those infections are mildly or asymptomatic. So there's some natural immunity being produced, but it's also bad because it has just spread like wildfire. And it's really kind of rewritten the dynamics of this and where we were. If one looks back at March of 2020, we had limited testing. We had limited experience or no experience treating this. We had no therapeutics and we had no vaccine. And, you know, here we are in September 2021. We have ample testing across multiple different platforms. We've even got at-home testing. We have clinicians who have tremendous experience in treating patients with COVID now. And we have 3 safe and effective vaccines that are out there and widely available. So I guess my closing remarks are, I always want people to make their own healthcare decisions, but look at reputable sources. Don't just look at social media. Don't just listen to talk radio. Look at reputable sources regarding the vaccines, and please strongly consider getting yourself vaccinated. They are safe and effective. And while you might still get COVID if you're vaccinated, your chances of not getting very sick and surviving COVID are much greater if you are vaccinated than if you aren't. And I think that'll be my final comment for the day.
Yeah.
I just want to thank you all for being here. We really, really appreciate it. I think the message with when it comes from multiple sources, and especially sources that we respect, is better received. And like I said, my only reason to being here today is because I care. I really care. I don't want to go to any funeral. I don't want to see anybody else die. And I wouldn't be advocating for the vaccines if I thought there was a hazard to me or anybody else. I wouldn't be doing that. I wouldn't be ethical, and I wouldn't be moral. So my only intention is to save as many lives as we can. And I thank Jim and Randy for putting this together for us.
So as listening to what you've all said, it's a great transition to what I envision as our next discussion in a couple of weeks, because I would like to get into some of these other things you guys just mentioned. I made some notes, but then also the impacts to our service, line of duty deaths and severe illnesses that could possibly be prevented, and who knows. And so just be thinking about that. And to everyone that's watching, thank you everyone for watching, taking in part of this, and we will try to do it again. Thank all you physicians, and with that, we'll close it out, and I hope everybody has a good afternoon.
And Herb, remember, Star Trek, Star Wars, please, okay?
Yeah, I should never do those cultural references. It just it was a bad idea.
Yeah, we'll have no Jedi mind melds here. Thank you.
I think